Hi, good morning, good evening, wherever you may be in the world, and welcome to another NDD live training session. My name is Jamie Burgess, and I am a registered respiratory therapist, and my role at NDD is I'm the Global Training and Research Director. Thank you guys so much for joining us again, helping me out today. Darren is on the call to help answer some questions at the end of the webinar. Joy and Bianca, my normal helpers, are both out today. I hope they're having a fantastic vacation. But we're going to go ahead and get started with this live training on the EasyOne Pro LAB device. And we are going to primarily be covering that multiple breath washout test today for lung volumes. So we're going to go ahead and get started. So like you saw when you signed up, in this training, we're going to learn how to set up our device for that MBW test, a little bit different from the other tests that we do on the Pro Lab. How to coach a patient through an MBW maneuver, which arguably is the make or break to this test, is how we are coaching the patient through. Learn common test errors and how to continue to encourage that good patient effort. And then at the end, we always will save the last 10 minutes or so for an open Q&A where you guys can ask your questions. Of course, at any time questions come up, be sure to use, there's two different functions in GoToWebinar. There's a questions tab on your toolbar, and then there's also a chat bar as well. So you can look at either one of those and ask your questions. If for some reason we don't get to your question at the end, I do get everything that was typed into both that question bar and the chat bar once the webinar has finished up. And if it's something very, very specific, I can help get you in touch with support or reach out to you myself once the webinar has concluded. All right, we're going to go ahead and get started. If you attended last month, you'll know with the EasyOne Pro and Pro Lab devices, it's always a little bit hard to have them live on camera just because of the screen glare and multiple webcams and all of the difficulties that come with that. So we'll be switching our screens back and forth between pre-recorded tests, our EasyOne Connect software, and then of course looking at practical assembly items on the Pro Lab itself. All right, so this is a very, very wordy slide, but I wanted to include just the absolute textbook definition for the question, what is multiple breath washout? Most of us know that it's a way to determine a multi-breath lung volume or a TLC-MB parameter, but multiple breath washout has a few different names. You might have heard it referred to as nitrogen washout, as Fowler's method. What this really does is a test for measuring anatomic dead space in the lungs during a respiratory cycle. It can also give us some other parameters related to how the closure of our airways. During a multiple breath washout test, the subject takes in breaths of 100% oxygen and then exhales through a one-way valve, seeing how long it takes for them to completely wash the nitrogen out of their lungs. So a plot of the nitrogen concentration, or the percent of the total gas, is compared to the expired volume by increasing the nitrogen concentration from 0 to the percentage in the alveoli. This nitrogen concentration is initially 0 because the subject is just exhaling that dead space oxygen that they breathe via room air. That increases as alveolar air mixes with dead space, and that is how we get our measurement. So most people with a normal distribution of airway resistance will reduce their end-tidal nitrogen to less than 2.5% within 7 minutes. You'll actually see a video of me doing the test when we get to that portion, and I normally wash out in about 2 minutes, and I actually do have an obstructive disease. I have asthma. Some people with really high airway resistance can definitely go beyond that 7 minutes, which is why learning how to coach through this maneuver is so important in order to get a successful test and reliable results. So what are some common parameters that we see in a multiple breath washout test? On the right-hand side of your screen, you see what is located in every respiratory textbook, and that is the label of the complete respiratory cycle with all the different parts and pieces that make up our TLC or our total lung capacity. So we'll start off with that TLC. This is the volume in the lungs at the maximal inflation. So the biggest breath in, and then the sum of our vital capacity and our residual volume. So starting with the first line of respiratory pattern, the tidal volume is the air that is moved in and out of your lungs during quiet, normal breathing. The vital capacity is the air that's breathed out after the deepest breath possible. You can see that here on this side of the graph. The VA is the alveolar gas volume, so what is being held in the actual alveolar space. And then the ratio between the TLC and the VA, how much total air versus what is being used for a gas exchange or that alveolar gas volume. All right, looking down here at the very bottom of our chart, that bottom of the lung value, when you fall as a kid and get the air knocked out of you, that's when you would lose your residual volume. It's the air that normally is remaining in your lungs at all time after even a maximal exhalation. The ERV is right above that, our expiratory reserve volume. That's the volume of air that can be exhaled from the end expiratory position. IRV is the opposite, so the maximum volume that can be inhaled from the end of an inspiratory regular breath. Our FRC, looking kind of down here at the bottom, which is a combination of our ERV plus our RV, so the volumes at the end of an expiratory position. And then last but not least, our LCI. LCI is not a volume measurement that you're going to see on the right hand of your screen, but this is a measure of ventilation distribution. How well evenly distributed we are ventilating our lungs. And this is obtained from this multi-breath washout test. All right, one question that we get, I think more than any other question when it comes to the multiple breath washout test, is we will have people call into support. You'll call your regional director or your sales representative and say, you know, we're doing multiple breath washout. We're missing our TLC. Our TLC is not calculating. And so the first question that we always ask is, did you perform an SVC test or a slow vital capacity test? And if the answer is no, then that's absolutely why you didn't get your full values for TLC. So in order to have that TLC value in the multiple breath washout test, an SVC or a slow vital capacity test must be performed during the same session. This will fill in those blanks that are needed to calculate that multiple breath TLC. And while, of course, this is a multiple breath washout training, I didn't want to skip past SVC. There were a few changes to the SVC test with the 2019 ATS ERS standard for spirometry update. And so I just wanted to very quickly go through the technique of an SVC test, because again, it is one of the most important parts of making sure that we have a good TLC from our multiple breath washout test. So there are actually two methods that our devices will recognize for performing the SVC test, the IRV method and the ERV method. This is not something that you have to enter into your device or save as a setting. The software in your EasyOne Pro LAB will automatically recognize which method you are performing, and it will adjust and the coaching bar will change dependent on how you start the test. The IRV method is exactly what we see in our respiratory textbook picture on the right-hand side of our screen. Tidal breathing is the same for both methods, both for IRV and ERV. And this is something that was adjusted with that 2019 spirometry standard update. And the patient's breathing needs to be relaxed and normal. Again, I always say small, quiet breaths to my patient. Steady tidal breathing now with the standard update needs to be established prior to the maneuver. So many of us were used to just doing 2 or 3 regular breaths and then coaching the patient through the SVC maneuver. We can no longer do that. We need to wait until steady tidal breathing is established, and then the device will prompt us to start the maneuver. if we have not accomplished that steady tidal breathing after 10 breaths, the device is going to go ahead and have us start the maneuver. So just as a reminder, your SVC test might have you regularly breathe longer than you were used to with the old 2005 standards. With the IRV, or the inspiratory vital capacity maneuver or method, after tidal breathing, this is where we're going to inhale first. So the patient must inhale all the way to total lung capacity and then relax and expire all the way down to the ERV. So it really does look exactly like this graphic. Normal breathing until the device prompts us, then coordinate with our patient to take a big deep breath in and then let it all out all the way below baseline, reaching our expiratory reserve volume. So moving on to that ERV method, this is kind of the exact opposite of what we did in the IRV method. And this method is really good for people that might struggle getting to that below baseline or below our regular breathing all the way down to ERV from all the way up top in our inspiratory reserve. So this method is a little bit easier for people with known lung disease, for them to be able to hit that expiratory reserve first before taking their big breath in. So as I mentioned, tidal breathing is the same in both methods. We still have to establish that steady tidal breathing, or it will prompt us at 10 breaths to start the maneuver. Coordinating with the patient. So now the first instruction after tidal breathing is we're going to have our patient exhale all the way down to ERV, and then when prompted, take that big deep breath in all the way up to TLC. And again, neither method is incorrect. You might have some patients where you kind of need to see which method they get the best values or the best effort from. Again, as an asthmatic, I do find the ERV method much easier to get all the way down below my baseline to that ERV number versus doing it the opposite way. All right. Some tips and tricks on SVC before we do a quick demonstration of that test is we want to make sure that we are encouraging our patient to reach their maximal inspiration and maximal expiration at a really consistent or constant flow. Again, this is not a forced maneuver like traditional spirometry, our FVC, FBL maneuvers, but we do want to make sure that the patient is breathing at a constant pace. The maximal inspiratory and expiratory levels need to be reached between about 5 to 6 seconds. For a patient with obstructive diseases, this is obviously going to take longer getting all the way to that expiratory plateau, but expirations should be stopped after 15 seconds, just like in our spirometry maneuvers. Again, this maneuver is relaxed, it is not forced, and at the very, very end of expiration, if we need them to push out a little bit, that's all right as well. So maneuver quality, this does have an inspiratory component into it. So we really need to make sure that the patient is not leaking around the mouthpiece or through their nose. So obviously, to prevent leaks around the nose, a nose clip in place is always recommended. Make sure that there's no obstruction on the mouthpiece. Sometimes people like to play it like a trumpet or put their tongue in the way, just making sure that they have a good tight seal with their teeth on top and tongue on bottom so that there's nothing in the way of the mouthpiece. The maneuver should not be too slow. There should not be any hesitation. And again, just like in regular spirometry, we don't want a glottic closure. So making sure that the patient maintains good posture throughout the maneuver is very important. So if we are not looking at these things, it might lead to an underestimation of their inspiratory capacity, which will affect our multiple breath washout numbers as well. So we really do want to make sure that we are getting full efforts on both sides of the curve from our patients. All right, I am going to go ahead and swap my screen over to the EasyOne Connect software. And I'm just going to do, again, I want to make sure we focus on multiple breath washout, but I also did want to go into the SVC maneuver just to do a quick demonstration. I'm going to do both the IRV and the ERV methods so that you guys can see the difference in the coaching messages on your screen. All right, so I have already selected myself as a patient, and I can confirm my patient identity in the lower left-hand corner of my screen. I'm going to go to test. I'm going to go to the SVC test. I'm going to confirm or update my environmental factors and click confirm. The first thing it's going to ask me is if I am using an inline filter or if I am not. For the EasyOne Pro, obviously I am demonstrating this on my EasyOne PC because of the ease of screen sharing. For the EasyOne Pro and Pro Lab, you should always use the patient side filter in your Pro filter kits, even for spirometry, even for SVC. You're going to use the exact same filter setup for every test that you perform on the Pro and the Pro Lab. And I will have a picture of that when we jump over to the multiple breath washout test. The next thing it's going to ask us to do is to block the spiret until prompted to blast out. And then once the coaching bar tells me to begin the test, I'm ready to start that steady tidal breathing. So again, I'm going to demonstrate the IRV method first. All right, you'll see that the test did end automatically once I got to that point of expiratory plateau where no more air was coming out of my lungs. You'll see that the coaching bar is now telling me that that was a good effort and to repeat the trial. Just like with spirometry, SVC, the rules are the same. We need to have a minimum of 3 acceptable and reproducible trials before the session will end for us. All right, I'm going to go ahead and click add trial, and this time I'm going to do the opposite. I'm going to do the ERV method, where after baseline breathing, we're going to exhale first. So keep an eye on the coaching bar because it will automatically know that I have changed methods. Excellent. And again, it is going to automatically end when it has that end of flow at the end. So you can see here kind of the 2 different methods kind of superimposed on each other here on my flow volume graph here. And if you look down at my trial 1, trial 2, again, being an asthmatic, my vital capacity is always going to be more when I have the opportunity to exhale first. And again, you might need to use both methods to see what's going to work for your patients. All right. Again, in a real world, we would complete the trial with 1 more test, but because we want to make sure we focus on the multiple breath washout test, I'm going to go ahead and end my session here with SVC and move on to the multiple breath washout test. All right, so I'll make myself bigger for just a moment here. So when we're getting ready to set up our Pro Lab device for multiple breath washout, there's a couple of things that we need to understand. We should already have our spiret inserted from spirometry or SVC or even DLCO prior to doing multiple breath washout. But just as a refresher, we always want to make sure that we're inserting our spiret mouthpiece arrow to arrow. And I'm also going to show you the example with both of our mouthpieces for the Pro. So on the Pro filter kit, it's not, I don't have this one colored in, but there is the arrow on the top of the mouthpiece. And then as you can see on this mouthpiece, I have colored it in the arrow on the top of the spiret. So whichever option you're using, again, you would use this for your complete PFT, or you would use this. You would not need to switch back and forth between solutions. All right. So to disconnect our handle from our motor block, there is a silver button. We're going to slide that until those arrows are lined up on one top of each other, and then lift that off. Make sure that we always line up the arrows before we lift the motor block off, just because that can bend our pins. All right. So just like I showed you guys on the other mouthpiece, you'll see that I have colored all of these in after multiple years now of virtual training, but you'll want to make sure that the arrow on your mouthpiece is lined up with the arrow on your hand sensor. Make sure that it's pushed in all the way flush. If you happen to have it in upside down or not in far enough, it is going to give you an error that the spiret is inserted incorrectly. All right. Same thing with the other mouthpiece. If you're using the Pro Filter Kit, you would line up the arrow on the top of the Spiret FA with the arrow on your Pro Lab handle and push it all the way in to where it is flush against the handle. All right. Now, if you are doing the DLCO test, you know that the DLCO test and then the multiple breath washout have two different bariettes. So moving from either spirometry straight to multiple breath washout or moving from DLCO into multiple breath washout, we will need to make sure that we have in place that multiple breath washout or the FRC barriette. The FRC barriette looks a little bit different from our DLCO barriette because it does have these little wings on it that allow the patient to exhale out of the one-way valve. All right, the arrows on these are hidden a little bit below those wings, but you do want to make sure that you're inserting the barriette directly on top and pushing it down so that those arrows are kind of nested inside one another. Once your barriette is put in place, you would again, let's get this a little bit closer, you would again line up the arrow on your motor block with the arrow on your mouthpiece, lining those up, and then sliding the motor block forward to click it into place. Right? Now our device is ready for the multiple breath washout test. Right? I do have an e-tank hooked up to my device. When you turn your gas tank on, you do want to make sure that you fully open the valve until it stops turning. So make sure that that valve is completely open prior to testing. You'll also want to make sure that your flow rate, which will automatically reset with the device until you change out your tank, but you want to make sure it's set within that 5 to 6 bar range or at the top to a little above your green markers if you're using the Concoa regulators. So once we've confirmed that our device is set up correctly for the test, our gas is all the way turned on and ready to use, we'll be ready to start the multiple breath washout test. Now, I always tell patients, as long as they are listening to their coach during this test, it is really an easier test for the patient to perform, less effort for them to perform this test, because what we are really doing is coached tidal breathing. The biggest thing with this is really making sure that you continue to coach the patient through the entire maneuver. I know that there are some of you on this call that have done pro lab trainings with me before, and I really do count for my patients the entire maneuver so that they know exactly how much air to breathe in and then at what pace to breathe out. For my pulmonary people and my respiratory therapists on the call, what we are essentially doing for this patient is setting their IE ratio or their inspiratory to expiratory ratio, just like we would set manually for a patient on a ventilator. We want to make sure that we are not just dead space ventilating from here to here. We want to make sure the patient is fully filling and then completely continuing to push the volume out of their lungs. We will talk a little bit about common errors later, but one of the biggest things is patients get a little bit nervous when it's a longer test. There's not as many instructions from the coach, and they really do start to hyperventilate. They start to breathe very quickly, not actually fully emptying their lungs, and that can cause some problems and cause the test to be longer than it should be. So I really do coach my patients all the way through to breathe in, and I count their exhale, exactly setting their IE ratio for them. So I'm going to hop back over to my slideshow. All right, and we're going to go into this video. All right, I'm going to kind of talk through this first one here. So you'll see where the SVC test and the MBW test are located on your test menu. It's going to have you confirm whether you're using the filter kit or not. And then it's going to go through the 5-point check. This is checking for internal leaks, leaks from your gas tank. It's checking the gas composition, the environmental factors, and getting the device ready to test. During this point, I am still holding on to the handheld for my patient. I really don't hand that over to them until it's time to test. You'll notice a few different things on this screen. One of the most important being that volume in liters graph on the right side of your screen. When we apply nose clips and instruct the patient to start breathing, you're going to see when they take air in, that bar is going to rise on our volume meter. And our goal for their inspiratory is to be in that highlighted section that is green. So for this patient, the entire time, I would be telling them to breathe in and out. 2, 3, 4. Breathe in and out. 2, 3, 4. Breathe in and out. 2, 3, 4. It seems very repetitive, but it really is necessary for most patients to have that coached breathing, even though it's regular tidal breathing, to have that coached by the technician doing the test. As you can see, the oxygen just kicked in. We can now see our respiratory rate just to the right of our inspiratory gold bar. You'll see right above that concentration of nitrogen slowly but surely stepping down. The red bar that you see is that magic 2.5% nitrogen. We want them to continue to regularly breathe at a coached pace until they have 5 breaths below that bar. And then the test will automatically be ended by the software for us. So again, I really do coach them this entire time. We want to keep that respiratory rate less than 15. We want their inspiratory to be into the green and then out for 4, making sure that they have fully exhaled. Again, it does sound very repetitive, but breathing in and out. 2, 3, 4. Breathe in and out. 2, 3, 4. You'll see that I have now gotten below that red line. So the test has ended automatically and it has sent me over to my results screen. All right. So again, I washed out in a little over 100 seconds. So some people will be short like that. Other people, it will take that 7 minutes to wash out, which is why coaching them through that relaxed breathing is so important. A few things to see on the screen here. We can see the step down of nitrogen in 2 different places, in the center of our screen and then in the upper right-hand corner. We'll see our flow rate right above that we do want to keep under that 2 liters a second, so they're not taking huge, enormous breaths that will take forever to wash out. And excuse me, on the flow rate, and then on the volume, you can see that in the top. All right, down in the lower left-hand corner, you will see all of your real-time values. I have a lot of different values selected that I like to see while I'm doing the multiple breath washout test. In a second, I do think that I scroll the mouse down in the video so that you can see all the different parts and pieces. But remember, if we are missing a parameter out of SVC, so we didn't have an ERV, we didn't have an IRV, you're gonna see that your TLC in multiple breath washout is blank, because we really do need those missing puzzle pieces from the SVC test to be able to give this multi-breath TLC parameter in our test results. So you'll also notice that similar to DLCO, there is a countdown. We really do, the countdown gives us a number. We need to make sure that we're not restarting our second effort until after that countdown is complete. If your patient took a very long time to wash out, so say you had a patient and it took them 10 minutes to wash out, regardless of the countdown, we need to make sure that we are waiting at least the amount of time that it took for them to wash out, so that we're confident that they are back to baseline before doing a second maneuver. All right, I'm going to go ahead and click play on the video here. I will probably speed it up here just a moment. All right, you'll see here I am scrolling down so that you can see all of the different parameters that I have plugged in. If you see that my reserve volumes are low, you are correct. I am an asthmatic who is still holding on to a little bit of long COVID, especially in my volume parameters. So nobody be concerned. I know my FRC is 45%, but we're still working on it. We're getting ready to do that second maneuver. Just like with DLCO, we always want to make sure that we do another acceptable maneuver so that we have that reproducibility to look at for our test quality. So you'll see under test information, I have a D grade right now, but that's because I only have one trial. Also below that, you're going to see your comment section. Anything that you need to relay to the person reading your test can be entered into that comment section. It'll ask you for a user ID. That can be your initials, that can be your single sign-on for EasyOne Connect, but just so that they know who is leaving the comment on the test. All right. It's going to go, when it launches back into the test, it is going to repeat that 5-point check, double checking for leaks, double checking environmental factors and the setup of the device before it launches into that second test. So we're going to go ahead and click start. And it's going to launch us back over into the test. Again, we do have that wait time while we're waiting for their lungs to return to baseline gas values. And we also have the 5-point check. Anything that might have gone a little bit wrong in the first trial, we want to make sure that we're using this time to coach them appropriately so that we have a successful second trial. As you can see, the gas is flushing, and now it's instructing them to start tidal breathing. So again, from the moment the mouthpiece is sealed and the nose clips are on, I am coaching the patient through this maneuver. Breathing in and out. 2, 3, 4. Breathe in and out. 2, 3, 4. Once you do some normal breaths on the mouthpiece, it's normally about 8 breaths before that oxygen kicks in. So you can keep an eye on how many breaths they've done just to prepare them, because there is a noise when the gas does first start coming in through the mouthpiece. That is when you will also be able to see your patient's respiratory rate. All right, so should be after this breath, the gas is going to kick in, and we'll start to be able to see a lot more of our test values. We'll see our stair steps, there they go. We'll also see our respiratory rate appear. We want to continue to keep them breathing through this. Sometimes if a patient needs to swallow, if they need to adjust their mouthpiece, it can cause leaks, which is in turn just entraining more room air and making our test last that much longer. So we really do want to make sure that we are coaching them, encouraging them to keep that tight seal, and really instruct them, set that IE ratio from the beginning of the maneuver all the way to the end. They will feel like you are repeating the same thing over and over again, but this really is as simple, in quotes, as this test is. It's normal breathing. We think, oh, it's just normal breathing. We can get through it quickly. Coaching them through, guiding the test from the beginning to the end really is going to set you up for much more success than trusting that they can normal breathe at a steady pace on their own. So you'll see that's breath 4 underneath that red 2.5% line. And then we're going to have one more breath before it clicks us over to that test results screen. There we go. At that point, we can have the patient remove the mouthpiece, take off their nose clips, and then I'm going to go ahead and pause again here for just a moment. So I am getting the session complete, great job message in the coaching bar. You can see over here in the test information that I have an A grade, looking at both the variability for my FRC and for my LCI parameters. They're both within range. So this test is reproducible from trial 1 to trial 2. Down here, you can see the trials are laid out right next to each other. I believe I do scroll back down again here, looking at all the different parameters that I have selected. At that point, I could then click on my report. In this example, I really do just have the multiple breath washout report showing, but most of us know that if you're doing a full PFT, there is an option to print from your drop-down menu in the upper left-hand side. I didn't pause it quite fast enough. There we go. Up in the upper left-hand side, you'll see that I do have the multiple breath washout only report selected. But again, if you are doing a full PFT where you're doing spirometry, SVC, DLCO, multiple breath washout, there are 2 different summary report options in your dropdown that you can select to show all of your tests on one single report. All right. Scrolling down a little bit here, you'll see the graphs for both the efforts down here at the bottom with all of our other values up top. All right, I'm gonna go ahead and stop sharing this application. Oh, no, I'm not, I'm in my slideshow. I'm going to click on to the next slide here. We're going to just discuss a couple of common errors that we see. Some of these we hit on a little bit during that coaching session, but just the most common errors that we hear about in the multiple breath washout test. And so that first one is that unsteady tidal breathing, why it is so important to coach the patients through a consistent breathing pattern from the beginning to the end of the test. Second is hyperventilation. This is why we put the respiratory rate right there to make sure that they are keeping that respiratory rate under 15 and having a good steady pattern. If a patient hyperventilates during the test, the end-tidal INTU and COT values cannot be determined. Hyperventilation can be recognized in 2 ways. The end-tidal CO2 values will decrease, and second, the increased breathing frequency will be shown on those graphs, both on flow, volume, and the nitrogen on the nitrogen graph as well. So again, making sure that they are breathing, the frequency and the tidal breathing are consistent throughout the majority of the test. And again, that's on us, the coaches. You can see here in my picture when I started just breathing very, very, very fast. Even if you're not watching your respiratory rate number next to your inspiratory gold bar, you can definitely see it here on all 3 of those waveforms. Another thing that is really, really common is a leak or a room air inspiration. Again, we should always see that steady stair step all the way back down. If a patient does entrain room air at any point in the test, either a leak around their mouth, a leak around their nose, we're going to see those stair steps jump back up and have to start working back down again. While our device will recover from a minor leak, we really, if the leaks are excessive or happening frequently, we would want to end that trial and start again, because recovering from those leaks is just adding more and more time to the test, which is going to increase the chance of error from our patients. So we need to make sure that this test, our patient is only breathing the 100% oxygen that we are delivering to them during the washout phase. Obviously, if the patient inhales room air, that nitrogen is going to go right back up again. So again, most commonly, it's a leak on the mouthpiece caused by, it's normally swallowing. It's always because the patient needs to swallow and they leak around that mouthpiece, or they're not wearing their nose clips correctly and it comes in through their nose. So we really do need to monitor the patient seal on the mouthpiece throughout the entire test, making sure that a brand new Spirette and FRC Barriette are used. This is not only a hygiene issue, but making sure that there's good tightness throughout the test. And also use a nose clip, use it properly every single time. I know it is not the most comfortable thing for our patients, but for any test with an inspiratory component, it is so, so important that the patient is using a nose clip. All right, we also get some questions sometimes on the acceptability and quality grades. We just talked about some things that would make a test acceptable, but the current software for the EasyOne Pro LAB contains a quality grading system for spirometry and DLCO. For multiple breath washout, this really hasn't been established. You know, ATS, ERS, they're really working on standardizing those lung volumes and that policy and procedure. But for MBW, what we are using is a grading system similar to what has been used in software, or excuse me, in spirometry, and that has been implemented into the software for the EasyOne Pro LAB. This helps us with that session quality grading and also what our end of test criteria looks like. This is based on the ATS ERS lung volume consensus statement. All right, So sorry, a little bit blurry here, but you can see what the breakdown of each of the letter grades is. For an example, for a letter A session quality grade, a minimum of 2 acceptable maneuvers with LCI variability less than 5% and FRC variability less than 10%. And you can kind of see how that changes as you move down the grading scale. Of course, always wanting to end with an A or a B whenever possible. And again, this is based out of the multiple breath washout consensus statement that was released by the ATS ERS boards. All right, that is it for our presentation. I do want to make sure that we leave plenty of time for questions. It looks like we're doing fantastic on time. So please, if you have any questions or comments, please enter those into the chat bar or the question bar at this time. Darren's gonna hop on. If we do not get to your question, again, some questions that are very, very specific, I would want to follow up with you one-on-one later, either myself or technical support. So if we don't get to your question, don't worry, I will still be able to see it once we have wrapped up the webinar by looking at my spreadsheet. I'll be able to see anything that you put into those question or chat bars. So Darren, are you there?
Yeah, I'm here.
Hey Darren, do we have any questions?
We do. I'm going to start with, it says, Jamie, if we have a patient with bolus, cystic lung disease, or areas of the lung that are poorly ventilated or due to a lot of obstruction, it's difficult for them to reach completion criteria on the washout. In this case, the ATS ERS guidelines recommend not continuing further beyond the 7-minute maneuver. This equipment stops automatically after 7 minutes if the completion is not reached, question mark?
So it will not, but you can manually end that maneuver at any time. Again, most patients should wash out under 7 minutes. We know that there are those exceptions that could, I mean, some of them wash out for 10+ minutes. Yes, we can manually end the maneuver, but because it's still registering volume, our device will keep going as long as the patient is able. But yes, you can manually stop the device at that 7-minute mark if you are aware of that patient's history or know that it's going to take them much, much longer to wash out.
Yes, thank you. Let me get to the next one. Comments that, a very common for patients to have, where the leaking happens is from the mouth due to dry mouth or dry throat. And how much percentage difference on the DLCO single breath to the multiple breath FRC?
So looking, I assume that you're asking kind of like on accuracy, like how they would compare. Some of that really does depend on the patient and their actual lung physiology. Obviously patients, we know that there is not like a perfect way to measure lung volumes. We wish that there was. We know that gas solution can underestimate. We know that body box can overestimate. We know that DLCO single breath, dependent on the patient condition, can go either way. So really looking at multiple breath washout, we really do kind of expect between the gamut of methods of measuring lung volumes, we can expect up to a 10% difference from method to method to method. Whether that's body box to multiple breath washout, DLCO to multiple breath washout, DLCO to body box, we know that there's going to be some variability there just because of how the maneuver is performed. And based on your patient's anatomy and their lung health at that time, different factors can affect what is going to be more accurate for that patient. But always, if you are comparing your single breath DLCO to your multiple breath washout TLC to your body plexmography, know that there is kind of a 10% gimme room with any of the combination of comparison between those three numbers.
Yep. Perfect. There's some conversation in regard to helping patients with facial muscle weakness or to facial paralysis, that there's a mouth seal can be helpful in maintaining seal instead of a mouthpiece, especially in older patients. Yes. There's, I think, a physician on here, Dr. Maida, who has used a micro pore tape to close the mouth in case of facial weakness and has had success with that. So
yeah,
obviously
that's awesome. Yeah. Yeah, because I mean, it really is. It can be a struggle. There are, we do have a device, with a holder if they're having issues with the motor skills, holding the mouthpiece in place. Like you said, having a mouth seal. A lot of people will use like a Bennett seal, like they use in bronchoscopy, to make sure that they have that good tight seal. So again, anything that we have at our disposal to help them maintain and not entrain room air, especially around their mouth, because it is hard. I think last night when I was kind of doing some of these recordings, I was having trouble sometimes making sure don't swallow, don't swallow, don't swallow, because it can be for some patients a longer test. So anything that we can do to assist them, whether that's holding the mouthpiece in place, whether that's using tape, whether that's using like a bronchoscopy seal, a mouthpiece seal, a bite block, whatever we need to do to maintain that seal throughout the test, 100% would encourage that.
Yep. Dr. Maida would like to know if we could share a picture of the micropore taping patient. I don't know if you can do that on here, Dr. Maida, or if you want to share that with me.
You can definitely try. If you see a way to upload it in the questions, absolutely do that. If not, I mean, please, yes, send it to me. Send it to me so that I can see it. Yeah, that's fantastic.
Yeah, and I don't know if this is a question, but it says we can get TLC and FRC results on SVC ERV method with the washout, I'm guessing is.
Okay, so yes, so a lot of people, so like I was saying, on the SVC, always add your IRV and your ERV to the parameters that you see as a technician doing the test. Because again, doing the IRV method especially, obstructed patients are gonna have a hard time getting all the way back down below baseline. And if you do not get an ERV in your SVC, it is not going to carry over and give you a TLC then in multiple breath washout. So experimenting with your SVC methods to confirm that you have both an IRV and an ERV in SVC, or a reserve volume and an inspiratory reserve to carry over. Make sure that you can see those parameters, because you're right, sometimes those get missed in SVC, even though you did an SVC and it looks really good. Like I said, I see this the most in obstructive patients that are trying to do the inhale first method. Swap them to exhale first, confirm that you are getting all of your different volumes in SVC, and then they should populate over to TLC.
Yep. We get this question a lot, but it's, what do we do about dentures? What do we suggest about?
Yes. All right. So same rules across the board for dentures, in my opinion, and that if they are well fitted and secure, your patient is going to be able to create a much better seal with them left in place. If they are ill fitted, not secure, too big, too small, then obviously they're going to be more of a hazard for your seal than a helper for your seal. So just confirm that they are well fitted, well secured, because if they are, they're obviously going to be able to keep a much better seal with them in place versus just taking them out. So really it is dependent on the patient. If they fit well, if they're secured, leave them in. Otherwise, take them out.
Okay. I don't see any other questions at this time.
All right. Well, again, if you have questions, of course, my email is on the follow-up emails.
Virginia.
Go ahead.
Virginia has a question. I think she's going to type it, probably typing in.
Okay, yeah, that's fine.
Give you a minute, Virginia.
Yeah, while we're waiting on that question to come through, remember guys, you will get a recording of this webinar tomorrow. It will have my contact information on it. If something comes up after the webinar and you have a question, patient report you want to send for me to look at, any of those troubleshooting items, feel free to reach out once the webinar is concluded. Again, you will get that recorded presentation in your email tomorrow. Whether you attended all of the webinar or couldn't make it today, you guys will be able to have access to that.
Can we do multiple breath washout at 97% oxygen? I think we have that.
At 97. So, I mean, if it's coming, so through the device, I mean, it's going to be, I mean, we need to be using 100% oxygen as our source. So whether that is out of an E tank, whether that's out of an H tank, or whether that's out of a quick connect in the wall, the source needs to be 100% oxygen.
Mm-hmm. And going back to that oxygen is something similar. Is any suggestions on taking care of patients on oxygen, nasal cannula 3 liters per minute during MBW?
So this is something that you really do need to discuss with your physicians who are ordering the test. If the patient is on like a baseline 3 liters all of the time, they can't come off. That's normally kind of the determination. Will their sat drop below 90% during the exam? You know, giving them 10, 15 minutes off of their oxygen. Do they drop below 90%? We probably need to leave them on the oxygen for the exam and make sure that we leave a comment that the patient started with baseline of a 3-liter nasal cannula. Again, that is not, that needs to be confirmed with your physician. That needs to be something that's written into your lab's protocol. If a patient can maintain for the short amount of time on the test without, I mean, the recommendation would be for them to start at a room air baseline. But again, that's very patient dependent. Some patients cannot, even at rest, go that long without their oxygen, even though it's just 8 breaths before the oxygen on the device kicks in. If they can manage to stay above 90%, I would say take them off, wait 10 minutes and do the test so that you can start at a true baseline. If they cannot come off of their oxygen, just make sure that you're leaving a note for your physician. And again, that's something that individual labs need to establish with their providers, what that policy and procedure is going to be for those patients. That is just kind of the general recommendation that I have heard from labs all over the country, is they kind of do a little bit of a resting room air trial. Kind of using that 90% as their benchmark. But again, that's going to be different from facility to facility based on provider and lab preference.
Perfect. Then it says, you kind of answer this question, minimum SpO2 at which you should complete a PFT. Obviously, we see a lot of the times after washout, since they're getting oxygen, their stats say pretty up. Yeah. Medical assistant and do the basic PFT, but I think I could use additional training to ensure adequate. Yeah, Virginia, feel free to reach out to Jamie and we'll help you get that additional testing. Absolutely. Not a problem. We have Jamie does a great job of uploading training videos on our website. So there's a lot on there. You guys can go back and watch if you have someone in your office. What is the easiest way to test maneuver of MBW, or before a test, a patient can drink water because due to the 100% oxygen, throat getting dry? Yes, we always usually recommend if they can have a glass of water there for the patient to take a drink before starting the test. Sometimes
in between trials. Yeah,
exactly. We try not.
Yeah, absolutely.
Oh, thanks, Madeline. The easiest. Yeah, so that's I think those are the rest of the questions, Jamie.
All right. Again, feel free to reach out if things come up after. If you do feel like you need a little bit of extra training, we have lots of different resources, from e-learning courses to these live trainings, to trainings with your, some paid different options for one-on-one consults with our respiratory therapists, even the option of, paying to come back on site for training. We want to make sure that you guys are successful with this test, and we want to do whatever we can to partner alongside of you so that you're comfortable and confident testing patients on your Pro Lab device. So please reach out if you have questions. If not, have a fantastic rest of your afternoon, fantastic last day of February, and we will see you guys again next month. I think we're cycling back to the EasyOne PC device for March, and we will see you then. Have a fantastic day.